All right, so today we're going to put on our detective hats. We're going to follow the clues hidden inside the human body to solve a really perplexing case of sudden weakness. And we'll do it using a powerful diagnostic blueprint. Let's get into it. It always starts with something simple, something almost anyone can relate to. An everyday task, like walking upstairs, suddenly becomes a real challenge. This is our very first clue in a medical mystery that, believe me, unfolds very, very quickly. So, let me introduce you to our patient. He's a 48-year-old man, and he's walked into the emergency department with a problem that has just gotten progressively worse over only 4 days. It's a classic medical puzzle. What's causing this sudden progressive weakness? And the clues, they start to pile up fast. This is not just one thing. It begins with groceries feeling heavy, trouble with the stairs, but then a deep aching pain sets in. Then comes tingling in his hands and feet, and even a little bit of trouble swallowing. The whole picture is becoming way more complex, and honestly, pretty alarming. Now, the doctors run some tests, and they confirm it. This isn't just him feeling tired or fatigued, it is true objective muscle weakness. And that becomes the central question of this whole investigation. I mean, with symptoms this widespread, where do you even start looking? Well, here's the thing. Neurologists don't just take a wild guess. They have a blueprint, a really systematic framework for solving exactly these kinds of cases. You can think of it like a detective's toolkit, perfectly designed to sift through all the clues and narrow down the list of suspects. And here is that blueprint. These 5 questions are the absolute core of the investigation. We've already answered number 1. Yep, it's true weakness. So now, we're going to use the other 4 to systematically crack this case. This is our roadmap. This flowchart here just perfectly illustrates the whole process. See, over on the left, you start with the clinical facts. That's the patient's story and the exam. Then you move to the middle, you interpret those facts to figure out the anatomic diagnosis. In other words, you figure out where the problem is. It's only then, on the right, that you can figure out the final etiologic diagnosis, the actual cause. It's this incredibly disciplined, logical path from symptom to cause. Okay, on to question 2. What is the pattern of the weakness, right? Is it just on one side? Is it in his hands, his legs? The specific pattern is a massive clue that helps us zero in on the problem's location in the nervous system. The physical exam reveals a really crucial pattern. So on a 5-point scale for strength, his is only a 3 out of 5 in his shoulders and hips. Those are the muscles closer to his torso, what doctors call proximal. But his strength is actually better in his hands and feet, or distally. This very specific proximal pattern of weakness, well, that's a major clue. All right, on to question 3, and this one is a big deal. We have to figure out if the problem is in the upper motor neuron system or the lower motor neuron system. And really understanding this difference is absolutely key to localizing the issue. I want you to think of your nervous system like a chain of command. A signal to move a muscle, it starts way up in the brain's cortex, travels down the spinal cord, and then it gets handed off to a whole new set of nerves that go right to the muscle. This map here lays out that entire pathway for you. Here's a really simple way to think about it. The upper motor neurons, or UMNs, they're like the management. They live up in the brain and the spinal cord, and they're the ones giving the high-level commands. Then you have the lower motor neurons, or LMNs. They're the workers. They take the order from the spinal cord and they carry it out, telling the muscle exactly when to contract. What's so fascinating is how the body tells you where the problem is. So in management, the UMNs are damaged. You get one set of signs, like super overactive reflexes and tight, rigid muscles. That's called spasticity. But when the workers, the LMNs, are damaged, you get the complete opposite, decreased reflexes and link floppy weakness, which is called flaccid. And boom, here is our next major clue from the physical exam. When the doctors tapped our patient's tendons with that little reflex hammer, the response was barely there. They call it trace throughout. So let's put our detective hats back on. We look back at our chart, and we see that reduced reflexes, a condition called hyporeflexia, points directly to a lower motor neuron problem. This is a huge step forward. We've basically just eliminated the entire management system, the brain and the spinal cord, as the main source of the problem. So just as the team is zeroing in, a lab result comes back that seems to solve the entire mystery in one single moment. It's a classic case closed moment. Or is it? The patient's potassium is low, and this is a bombshell. Low potassium is a famous textbook cause of exactly what we're seeing, that flaccid, LMN-type weakness. For a second there, it really seems like the case is solved. just a simple metabolic problem. But then you get the twist. The doctors correct his potassium levels, they bring them right back to normal, and nothing happens. The weakness is still there. That easy answer, it was a total red herring. The real culprit is still out there, and now the investigation has to go much, much deeper. With that deceptive clue now out of the way, the team can finally get back on the right track. They have to use the evidence they've gathered, the pattern, the LMN signs, to pinpoint the true location of the problem. Let's go back to our map of possibilities. Weakness can come from one of 5 main areas: the brain, the spinal cord, the peripheral nerve itself, the neuromuscular junction, that's the tiny little gap where the nerve signals to the muscle, or the muscle itself. And this is where all our detective work really pays off. Remember that trace reflexes clue? It told us it's a lower motor neuron issue. Well, that means we can literally cross off the 2 biggest suspects on the list, the brain and the spinal cord. The problem has to be in one of the 3 remaining locations. We have just narrowed the search field dramatically. And this reveals what might be the most important lesson in this entire process. You see, the first goal in neurology isn't to just name the disease, it's to find the address. It's to answer the question, where is the problem? Because once you know the location, then you can figure out the cause. This whole case really teaches us something fundamental. When you're faced with a complex, totally overwhelming problem, the solution isn't to guess at the final answer, it's to follow a logical process, to ask the right questions, and to first figure out where the problem is. Only then can you truly find the solution.